So coming to the hepatobiliary system, it's a system which gives us a lot of opportunities to do various interventions and a little bit safer than the other side of the body, that is spleen, where it is really fragile thing and we are really at high risk of doing interventions. So in this system, we come across vascular and non-vascular procedures. The non-vascular stuff like the biliary drainages have already been covered yesterday. So we'll restrict ourselves to simple procedures like biopsies and some of the tumor ablations. The vascular, again, sir has recently covered the GI bleed. So we will again restrict ourselves to the more of liver-directed tumor management in hepatobiliary system. So coming to the biopsy first, I think even if this is a small and simple intervention, I think most of us are doing it. And that is the commonest call that we get in all of the radiology departments. And even if we are doing it daily, we still encounter situations which are difficult. So as it is a common procedure, I will not go into the technical details, just will have some tips and tricks to how to tackle the complications. So has anybody come across situations like biopsies with patients with ascites or deranged coagulation and has come across any complication of biopsy? Say, whosoever is doing biopsies must have come across some complication. So, so we'll see how in patients with ascites we need to do the biopsies. There is one more interesting procedure which helps us in situations where the coagulation profile is deranged, and that is transjugular liver biopsies. So these are the procedures which we should know, because we may get calls for patients with high risk ascites or coagulation where we need to do the biopsy. So a simple trick that initially we used to be afraid of doing biopsies with patients with ascites, cirrhosis, deranged coagulation. But not in many cases you can refuse the procedure because patient doesn't have any other option. And almost 30% of patients in our setup, at least, they come with ascites. So we still need to do the biopsy. Over a period of time, we developed a technique that helps us to tackle the situation. So first, I will, this is just to distract from a post-lunch break. And I need to stress upon the fact that we are in a diagnostic setup. We need to, whenever we are taking a patient of biopsy, we change the mode to the biopsy mode. We also need to change our mode as a diagnostic radiologist and our mood to be a non-invasive radiologist and go into the invasive mode. And